I'm Anissa Mitchell with PMD Alliance, and so glad to have you in this conversation, very important conversation that we're going to be talking today about PD Dementia and Psychosis. I know Dr. Weintraub is going to cover some other forms of dementia as well that can experience psychosis. I'm very excited about this conversation. This is a really important topic. Can't know enough about it. So before we get started, just a bit of housekeeping. I would love it if you would open up your chat box. If you haven't already, give us a shout out. Let us know where you're joining us from. And that's where you're going to be asking your questions. So when we get through the presentation today, we'll be watching the chat. I'll be gathering the questions for Dr. Weintraub, and we'll go through those at the very end. So I want to introduce, if you are not familiar with Dr. Weintraub, we have had him on before, but I'm excited to have him back again. He is in the movement disorders world, very well respected and renowned geriatric psychiatrist. He's a professor of psychiatry at the University of Pennsylvania. And his areas of interest and research is the psychiatric and cognitive complications of Parkinson's disease, delving also into a lot of the non-motor features. So we're very excited to have him. He's been very well published. He is an expert in the field. And so I know he's going to share a lot of great information with you. So I'm going to welcome Dr. Weintraub.
Thank you, Anissa. Hello, can you hear me okay?
Perfectly.
You can see me as well?
Yep.
Okay. And I guess I can go ahead and share my slides, so please let me know if I'm doing this correctly. So I'm going to share my screen, and I'm going to share this screen. And then I'm going to put it in presentations mode.
Okay, we're seeing it.
How does that look?
Perfect. Perfect.
Okay, great. All right. So I will go ahead and get started. I was going to make a few just very introductory comments. I'm going to have slides put together and I'll go through them, but there's also some time, I think, at the end if people just have questions or comments. We did decide to make this beyond just Parkinson's disease-related psychosis, because that information is embedded in a larger field of dementia-related psychosis or agitation, and I'll go through the details, but that's why this is a little bit of a broader talk. And there are slides that have tables and figures and data, and I don't mean to go through them in detail, but just use them to make points verbally that hopefully will convey the message that I want to give to you. All right, so that's the background. I've been doing this for 20 years now, both at the University of Pennsylvania and at the Department of Veterans Affairs. And as a psychiatrist, I'm trained as a psychiatrist, not a neurologist. I just focus on the psychiatric and cognitive aspects of Parkinson's disease. I don't manage the motor symptoms. I leave that to the neurologist. So that's my background and focus. All right, so these are disclosures, either research funding or support, honoraria, which typically involves being on scientific advisory board. And one of the companies to point out there is Acadia Pharmaceuticals, who I've been involved with over the years and is the maker of one of the compounds, medications we're discussing today called Pimavanserin or Nuplazid. And so that's the disclosure slide. And just a little bit about background, because I really want to focus mainly on management and what the research suggests about management of these symptoms in clinical practice. And there's some abbreviations that I'll use, and I try to highlight them in yellow the first time, so I don't have to keep writing out names of diseases. But so, for instance, Alzheimer's disease now will just be referred to as AD, and Parkinson's disease as PD, and so on. in the larger field of neurodegenerative diseases and psychosis, it's common that psychosis and agitation are considered together. So that's an important point to make, because some studies, particularly in Parkinson's disease, will focus on psychosis primarily, psychosis being hallucinations and or delusions. Hallucinations are an abnormal sensory experience, either visually or auditory, taste, smell, feel. And a delusion is a fixed false belief, so believing something is happening that other people don't believe is happening. And those should be occurring during the waking state, not part of a sleep state. So that's psychosis, and that's the focus typically in Parkinson's disease. But in the world of Alzheimer's disease, for instance, psychosis and agitation are often considered together. And the reason for that is because they often occur together. So somebody who's experiencing those hallucinations or delusions I mentioned, often with Alzheimer's disease anyway, may be agitated. So restless, resistant to care, aggressive in some way, disrupted sleep. Those are the kind of common manifestations of what we call agitation. So that's why they're sometimes considered together, and sometimes clinical trials are conducted on the basis of somebody having either one of those symptoms. They may have agitation but not have psychosis, but they would still qualify for entry into the study. And the 5 diseases that I mentioned here, really the 3 primary ones would be Alzheimer's, Parkinson's disease, and the related disorder related to both Parkinson's and Alzheimer's disease is dementia with Lewy bodies. But I also mentioned these other 2, vascular dementia and frontotemporal dementia, or FTD, because one of the studies I'll mention toward the end enrolled patients with any one of these 5 disorders. So we know that these symptoms, when they occur, are associated with all kinds of negative outcomes. They're very significant clinical symptoms often: worse quality of life and function for the patient, increased caregiver or care partner burden, institutionalization, higher rates of institutionalization, and worse outcomes. Increased risk of mortality or death. And that they're, most importantly, perhaps difficult to manage. So in the case of Parkinson's disease, but really any of these disorders, it's when you're talking about medication or treatment, which primarily involves the use of antipsychotics, you have to constantly weigh the risk versus the benefits. And that's what a good part of this, the rest of the presentation will focus on. So first we'll start with management of Alzheimer's, psychosis, and agitation, because that's really where the field started and where most of the work still has been done. And the main reason for that is about 5 times as many people have Alzheimer's disease as have Parkinson's disease, or probably even more than, the ratio is probably even greater than that. So it's just a much more common illness. It's been studied more clinical trials. And I'm just summarizing and picking some of the important ones. There have been a whole series of what are called RCTs, or randomized controlled trials. And that's where somebody is randomized or assigned to an active treatment, in this case, an antipsychotic typically, versus a placebo or fake treatment, as a way to determine if the medication is helpful or not. And this particular study is a twist on the design where patients are given the medication, in this case Risperidone, which is what's called an atypical antipsychotic, one of the newer ones. And then if they respond to that medication, the Risperidone, they're then assigned to continue the Risperidone or to go onto the placebo, the fake pill. And this study demonstrated, with many other trials it demonstrated before it, was that the likelihood of having a relapse or recurrence of one's psychosis symptoms or agitation symptoms if you have Alzheimer's disease is much lower if you stay on the Risperidone compared with the placebo. So I just use this one summary slide to show that antipsychotics do tend to help with these psychosis or agitation symptoms in Alzheimer's disease. That's been demonstrated in many studies. shifting to a different class of compounds, antidepressants. This was the major trial called the CITAD trial, or citalopram in Alzheimer's disease, that demonstrated that one of the commonly used antidepressants, citalopram, also known as Celexa, had a beneficial effect on agitation. In this case, it wasn't psychosis, but agitation in Alzheimer's disease. And this is just a figure showing that there was a separation, a statistically significant separation on this agitation rating scale between patients assigned to citalopram versus placebo over a 9-week period. So that was evidence for the effectiveness of antidepressants in this population. Now, sometimes things come out of studies that you weren't expecting. And one of the things that came out of this study was that citalopram was associated with some EKG changes on average compared with placebo. And it was a specific part of the EKG rhythm called the QTC interval that was increased compared in citalopram compared with placebo. And that's significant because if that increase becomes too great, then it can pose a cardiac risk to patients. And as a result of this study, primarily and other studies, citalopram is no longer recommended as the first-line antidepressant in older patients with depression, because once you reach a certain age, 60 and above, and a certain dose, 30 milligrams or above of citalopram, you really need to do routine EKG monitoring, and that's doesn't make it as feasible or practical to use. So sometimes these are the things you need to discover in these randomized controlled trials, not only whether a medication is helpful or not, but is there some adverse event or other adverse outcome that you weren't anticipating. Then there's been another compound. This is a long name, a hyphenated name, dextromethorphan quinidine, also known as Nudexta is the brand name. And this has been studied for agitation in patients with Alzheimer's disease and showed a beneficial effect. I won't go through the details. This is a compound that's actually FDA approved for the treatment of what's called pseudobulbar affect, or spontaneous laughing and crying that occurs most commonly in disorders such as multiple sclerosis or ALS, also known as amyotrophic lateral sclerosis, but can also occur in Parkinson's disease. And that's its primary indication. Dextromethorphan is a cough suppressant. Quinidine prevents the metabolism or limits the metabolism of the dextromethorphan, so more of it gets into the brain. And this is a study that was done in Alzheimer's disease dementia. Now shifting slightly to the compound that we will discuss later when it comes to Parkinson's disease. Just writing a note down for myself. Pimavanserin. So pimavanserin, also known as Nuplazid, that's the brand name. Pimavanserin is a generic name. Has a different mechanism of action than even what we call the atypical or newer antipsychotics, in that it only affects the serotonin system. 5-HT is the abbreviation for serotonin. Whereas the other antipsychotics, to some degree, affect the dopamine system as well. And that's particularly of relevance to Parkinson's disease, where we know that there's a dopamine deficit, less so in Alzheimer's disease. But before I even get to the Parkinson's story, here's a trial I just wanted to finish up the discussion of Alzheimer's disease, where this compound was tested for Alzheimer's disease psychosis. Because it is an antipsychotic. It was already approved for the treatment of psychosis in Parkinson's, so they tested it for psychosis in Alzheimer's. And this was a UK British study in nursing homes. And it did show at the primary endpoint, which was 6 weeks duration, a statistically significant difference in psychosis symptoms for patients randomized to the pimavanserin versus placebo. So statistically significant improvement for the active compounds. And that's what these figures in this bar chart show. All right, so now I'm going to talk about Lewy body disorder psychosis. And here the terminology gets confusing, and I apologize for that, but that's just the way it is. And Lewy body disorder, I wrote below, by that I mean two disorders. The primary one we'll discuss is Parkinson's disease, or PD, or it could also be considered dementia with Lewy bodies, or DLB. And I'm including both again because the study I'm going to mention down the road for dementia-related psychosis included both of these groups. So what do we know about dementia with Lewy bodies specifically? Well, not much, other than that the recommendation is in the treatment guidelines that really antipsychotics have to be used quite cautiously in this population because there may be increased mortality risk, there may be increased adverse outcomes because the DLB population in particular, dementia with Lewy bodies, seems to be particularly sensitive to the side effects of antipsychotic medications. So some of the examples that have been reported over time of adverse events include worsening Parkinsonism. Dementia with Lewy body patients typically have Parkinson's symptoms, fever, unresponsiveness, confusion, jerking movements, agitation, sedation. So this is a medical emergency when it occurs and needs prompt attention. So it's for that reason that you get these warnings about the use of antipsychotics in dementia with Lewy body patients. But I really want to spend more of the time talking about Parkinson's disease. So what was the evidence? And was means going back when this review was done in 2015 and before Pimavanserin came out, which was in 2016. What was the evidence for other antipsychotics? Because there have been other ones that have been studied. So the most commonly used one in Parkinson's disease, still by far, is called quetiapine, or Seroquel is the other name for that. But this figure shows this red vertical line going right through the heart of that green diamond shape, showing that there's no clear difference between quetiapine and placebo in the few studies that have been done. And the same is true for another atypical antipsychotic called olanzapine, or Zyprexa is the other name for that. On the other hand, an older atypical antipsychotic called clozapine or Clozaril, which is at the bottom of this slide, has shown statistically significant improvement in 2 studies. So that is clearly an efficacious compound for psychosis in Parkinson's disease. The problem with clozapine primarily is that it requires routine blood drawing to monitor for low white blood cell count. So because patients have to have their blood drawn routinely forever, it makes it less desirable both for the patients and for the clinicians to use that medication. I just wanted to show results of one imaging study that kind of gives biological plausibility to support the use of atypical antipsychotics and Pimavanserin in Parkinson's disease psychosis. Is this PET imaging study, as it's called, using an imaging ligand that binds to the serotonin receptors in the brain. And what it shows is that there's this upregulation or increase in serotonin receptors in Parkinson's patients who have psychosis compared with those Parkinson's patients that don't. So this and other studies, including autopsy studies, show that the serotonin system is dysregulated in patients with Parkinson's disease who have psychosis. And atypical antipsychotics are characterized by the increased 5-HT2A or serotonin to dopamine receptor binding. And the reason that's relevant is that we don't really use the typical antipsychotics or the traditional antipsychotics. Some of you may have heard of ones such as haloperidol or Haldol, because those are such heavy dopamine blocking agents that they're too problematic to use use in Parkinson's patients. They worsen the Parkinson's symptoms too much. So pimavanserin, as I said, was approved in 2016 for Parkinson's psychosis. That's its only approval currently. And on the left, this is the pivotal study. The results from it, some of the results, shows the outcome in terms of psychosis. So decreasing delusions, decreasing hallucinations, whether it's the top part of that figure on the left that's looking at a rating scale, or it's the bottom part of that figure that's looking at the site investigator or the clinician's impression of improvement. Either way, pimavanserin showed a significant benefit compared with the inactive treatment, the placebo treatment. And on the right, you have other outcomes, caregiver burden, and both nighttime sleep and daytime sleepiness, where you see an improvement with pimavanserin compared with placebo treatment. So less caregiver burden, better nighttime sleep, less daytime sleepiness. Now, we're going to go back to dementia-related psychosis. And now by that, I mean this all-encompassing term, dementia, that includes Alzheimer's disease, Parkinson's disease, dementia with Lewy bodies, vascular dementia, and frontotemporal dementia. And this is a study that was published last year. It was funded by the makers of pimavanserin, Acadia Pharmaceuticals. And it's called the Harmony Study. It was published in the New England Journal of Medicine last year. And this is the primary outcome for that study. It was the same kind of randomized discontinuation trial that I showed you at the beginning, where everyone is treated with pimavanserin first, and people who respond are then randomized to continue pimavanserin or are assigned to placebo treatment. And the fact that this placebo line is lower means that they had a higher rate of relapse of their psychosis compared with the pimavanserin group. So this was a positive study for pimavanserin in that regard. And what I'm showing you now is the subgroup of patients in that trial that had Parkinson's disease dementia. Everyone had dementia, including the Parkinson's patients. And this was presented at an Alzheimer's disease meeting last year, and the manuscript's already been submitted for publication or for review and hopefully publication. So this should be out in the literature soon beyond just this poster presentation. And what you can see here is an even more dramatic effect in this subgroup, in that almost nobody who was assigned to pimavanserin in the double-blind phase of the study, as it's called, relapsed, 1 out of 13 patients, whereas about half of the patients randomized to placebo relapsed over this time period. So this was a very robust, statistically significant effect in favor of pimavanserin in the Parkinson's disease subgroup of the larger Harmony study. And it supports then the primary study that showed a benefit for pimavanserin that I already showed you before in Parkinson's disease, and kind of extends it to that subset of Parkinson's disease patients who also happen to have dementia, so significant cognitive impairment. So that's the efficacy, or how well does the medication work side of things. But as I mentioned at the beginning, you have to also know how safe something is, how well it's tolerated. And that's been an issue of concern for antipsychotics going back a long time in people with neurodegenerative diseases. One study that really highlights this, and this is a lot of detail on the slide, so I'll summarize it, called the PD AD study, funded by National Institute of Health. And it was really meant to look at both the efficacy of the compounds, antipsychotics for agitation or psychosis in Parkinson's disease, and balance that within in the study outcomes against safety and tolerability. So patients essentially were randomized with Alzheimer's disease to one of three atypical antipsychotics. The ones that were used in the study were olanzapine, quetiapine, and risperidone. You've already heard of all three of those in previous slides, or placebo. And the primary outcome, which I highlight in bottom in yellow, is time to discontinuation of phase 1 treatment. So you can discontinue a medication either because it's not working or because it's not tolerated. And that's what this design was meant to capture, discontinuation for any reason. And from this 3-part figure, if you focus on the yellow line, that's the placebo line, the other 3 lines are the active treatment. You can see that the middle one is the lack of efficacy. And what that figure shows you is that patients were more likely to stop placebo because it wasn't working for agitation and psychosis. The figure at the bottom, where the placebo is at the top, means that they were less likely to discontinue because of poor tolerability or adverse events if they were on placebo. So it was better tolerated than the antipsychotics. And in this top figure, where I just put in any cause, you can see it all comes out in the wash. So the time to discontinuation for any reason was the same for placebo and for the active treatments, meaning that any benefit you got from the medication on average was offset by the adverse events and tolerability. So that's really gets to the heart of the matter of concern about antipsychotics in this population. And this was the summary. This was also in the New England Journal. Let's say that's over 15 years ago now. Adverse events offset advantages in the efficacy of atypical antipsychotic drugs for the treatment of psychosis, aggression, or agitation in patients with Alzheimer's disease. So that's just restating what I just said from the manuscript. So what are some of the other more rare but significant adverse events that can occur in dementia-related psychosis, as it's called by the FDA? And this is really what got it its black box warning. So it's a series of analyses of randomized controlled trials picked up a signal of increased morbidity and, even more concerningly, mortality, death, with antipsychotic use. The morbidity was strokes, those are cerebrovascular adverse events, and the mortality was secondary to possibly cardiovascular events and infections, although it's not really clear. But this signal that was picked up in the clinical trials led to the FDA issuing a black box warning, as it's called, for first atypical antipsychotics in 2005, and then typical antipsychotics, the even older ones, in 2008. So now all antipsychotics carry the same black box warning, including Pimavanserin. And then the other thing about particularly atypical antipsychotics, the newer ones, is that they're associated with some other side effects that can make them challenging to use in Parkinson's patients. Orthostatic hypotension, so a drop in blood pressure as one goes from a sitting to a standing position, which we already know can occur in Parkinson's disease, can also occur with these medications. Dry mouth, sedation, dizziness, constipation, all things that can occur in Parkinson's patients, even without exposure to these medications. And this is literally what the black box warning looks like. You can see a black box with text, and I won't go through all the details because it essentially says what I already said, other than the fact that this is not common. So you see numbers here like 4.5% and then 2.6%. So that's active treatment versus placebo. So that's about double in the active treatment, but still less than 5%. So if you subtract the placebo rate from the active treatment rate, you're left with about 2%, which means that about 1 in 50 people would be expected to experience this outcome due to the medication itself. So not a common event, but a terrible event, of course, when it happens. And this was further confirm this mortality risk in another discontinuation trial, also from the United Kingdom, where patients on a range of antipsychotics, Alzheimer's disease patients, and you can see the antipsychotics on the right, and this is in routine clinical practice, who had responded to the medication were then randomized to continue the antipsychotic or to go onto placebo. And what this study demonstrated, and it was terminated early because it demonstrated it quickly, was that staying on the medication longer term was associated with an increased mortality risk compared to those patients that came off of the antipsychotic over time. We did some research in this regard using the Department of Veterans Affairs database and Parkinson's disease, because all the literature I showed you about mortality up to this point had really been just in Alzheimer's disease. But we wanted to know if something similar existed for Parkinson's disease patients. And we did find that on the table on the left, that people that used an antipsychotic with Parkinson's disease compared with no antipsychotic use did have a higher mortality risk. And that was true for both atypicals and typicals. And it was true even for patients who were not diagnosed with dementia. So it wasn't just dementia patients, but Parkinson's patients in general. But what we weren't able to account for completely, and people have rightly criticized, is maybe it's just the fact, it's not the medication itself, but the fact that they have psychosis that was contributing to that, and other variables that make people who were put on an antipsychotic more likely to have to die, but not just the antipsychotic exposure. And that is one of the limitations of this kind of research, comparing those people treated with an antipsychotic versus no antipsychotic at all. So looking at safety and tolerability of pimavanserin, all of the literature I presented up until now did not include pimavanserin, these mortality risk and morbidity or medical outcomes. In the Alzheimer's disease study I presented previously for pimavanserin, there are the most common adverse events reported in the study overall were falls, urinary tract infection, and agitation, but there really was no difference, clear difference between pimavanserin and placebo. There were more serious adverse events, or what are called SAEs, in the pimavanserin group compared with placebo, but there were fewer treatment discontinuations due to adverse events in pimavanserin and placebo. The mortality rates were the same, and the pimavanserin was well tolerated from a cognitive and a motor standpoint. So really there was no signal for mortality or bad outcomes, adverse outcomes in this Alzheimer's disease study. And then since then, switching back to Parkinson's more specifically, there have been a couple of studies that have looked at the risk, mortality risk with pimavanserin, and these are using large databases. This one used an FDA database and compared pimavanserin users with no antipsychotic use or other antipsychotics versus no antipsychotic use. And basically what they found was that there was no safety signal before the media reports for pimavanserin, but then when some adverse media reports came out, for instance, on CNN about concerns about mortality with this drug, then the calls or reports to this FDA database increased, suggesting that it was partly being driven by the stories about the medication. And on the right side of this slide is comparing, it's presenting pimavanserin data, but also quetiapine data against, in this database, and clozapine and haloperidol and other antipsychotics. And what it really says is that the reported risk for pimavanserin was the same as with other medications. There was no relative increase in the risk associated with Parkinson's, with the risk of pimavanserin use compared with other antipsychotics that are also used in Parkinson's disease. But then there's been a subsequent study just published in a good journal, the American Journal of Psychiatry, that uses Medicare data and does something that's, I think, a little more informative, which is comparing pimavanserin to other antipsychotics. So not antipsychotic users to no users, but one antipsychotic to other antipsychotics. And this study showed that at least in the first 180 days of treatment, that mortality was actually lower with pimavanserin than with atypical antipsychotics. And that difference disappeared over the next 6 months. So from 6 months to 12 months, they were similar. But at least in the first 6 months, it was less with pimavanserin, so showing no increased risk in any way for this medication compared with other antipsychotics in Parkinson's disease patients. And then finally, our group, of which I'm a part of, I'm not the leader of this group, it's led by Dr. Allison Willis at the University of Pennsylvania, used a commercial insurance database, and just this month published an article. I'm just copying text in from this, not any tables. And what this did was similar to the last slide I showed, was comparing pimavanserin to other antipsychotics and dividing them into preferred antipsychotics such as quetiapine and clozapine and non-preferred agents, and showing no difference in mortality risk for pimavanserin versus other antipsychotics in this analysis, so just similar. So other safety data that's important to consider in Parkinson's disease is what is the impact of the antipsychotic on motor function and what is the impact on cognitive function. On motor, of course, because these are patients that have Parkinson's disease, and we know that some antipsychotics can worsen motor function. And cognitive, because we know from studies in Alzheimer's disease anyway, that antipsychotics have been associated with worse cognition over time in Alzheimer's disease patients. So this first slide from that Harmony study looking at the Parkinson's disease subgroup shows that on this ESRS, which is a measure of Parkinsonism or Parkinson's symptoms, there was no difference between active treatment, pimavanserin, and placebo on motor outcomes. So it's consistent with other studies that have shown good motor tolerability for pimavanserin in Parkinson's disease. The second part of this slide is looking at a cognitive test, a screening instrument called the MMSE, or Mini Mental State Examination, and showing the same finding essentially, is that no worsening of cognition with pimavanserin compared with placebo treatment in this Parkinson's disease dementia subgroup. All right, so now I'm up to the concluding slide, which is for dementia-related psychosis. That psychosis and agitation in dementia are common and overlap. They often co-occur, and they're common across many dementias. They also occur in neurodegenerative diseases without dementia, Parkinson's disease being a prime example of that. They're often problematic and require treatment, both for the patient and for care partners. Non-pharmacologic approaches, which I did not discuss and has not been studied much in Parkinson's disease, but more in Alzheimer's disease, can be quite effective. There have been good randomized controlled trials on interventions focused on education, support, different behavioral management techniques that have been shown to be beneficial for Alzheimer's disease agitation. We have evidence for efficacy for non-antipsychotic medications in Alzheimer's disease, such as the antidepressant study I showed you. In Alzheimer's disease, benefit for atypical antipsychotics may be offset by tolerability and safety concerns. And we don't know if that extends to Parkinson's disease as well, because there have been so few studies of other antipsychotics in that population. And in terms of the last compound that I presented, pimavanserin, its efficacy, tolerability, and safety data is good so far from multiple studies in multiple populations: Parkinson's disease, Alzheimer's disease, the Parkinson's disease dementia subgroup of Parkinson's disease, and with no signal for increased mortality compared with other antipsychotics. So whether it actually has a lower risk of mortality, I think is yet to be determined definitively, but there's no signal of an increased risk of mortality compared with the other medications that we use in this or other populations. So that's my last slide, and I will stop sharing my screen and turn it back over to you, Vanessa and Kelly.
All right, so we do have a few questions. Some of them are around disease state specifically, and then a couple in regards to medication. So let's start with the disease state first one, or to begin with. So the first one earlier, because again, the use of words is always so confusing. This person wants to know if dementia and Parkinson's is always Lewy body. So if you could you describe that a little bit better? It's just
right. It is. I agree. It's confusing, and we need a better way forward. It's just hard to get everyone to agree what changes to make. So Lewy body is actually a neuropathology term. So it's something that the neuropathologists use because it was named after the neuropathologist Levy or Louis, who discovered the folding of alpha-synuclein in the brains of Parkinson's disease patients, this misfolded protein that you'll hear about, into what are called Lewy bodies. So that is characteristic, that neuropathological finding, when you do an autopsy, of both patients with Parkinson's disease and patients with dementia with Lewy bodies. So Lewy body disorders often include both dementia with Lewy bodies and Parkinson's disease or Parkinson's disease dementias. So when somebody has Parkinson's disease, they already have a Lewy body disorder. We would only say they have Lewy body dementia if they develop dementia in the course of their illness, and then you could say they have a Lewy body dementia. But just having Parkinson's disease almost by default means you have a Lewy body disorder. It doesn't mean you have dementia with Lewy bodies, because that's a different clinical syndrome. That's a different terminology. And I'm sorry I can't give a clearer answer, but that's just the way it is right now.
It's just the current terminology.
That's right. That's right.
Well, and the question, I guess, that just came in that kind of extends that conversation is, are there any comments on a different manifestation of Parkinson's disease, psychosis, and Alzheimer's and other dementias? Like, I guess they're wanting to know, do those manifest differently? If somebody with Alzheimer's develops, obviously they have dementia and then psychosis, is there a difference in that presentation than somebody with other dementias?
I just think clinically, speaking from a clinical standpoint, I think the psychosis that occurs in Parkinson's disease may be a little bit distinct in terms of presentation, and that visual hallucinations are what are most commonly reported. And in Alzheimer's, that may not always be the case, or you may have also suspicious thinking more commonly early on. I think in Parkinson's disease, you can have it earlier in the disease course, and that may be partly because it's being driven by, in many cases, by the Parkinson's medications, or contributed to by the Parkinson's medications, which Alzheimer's patients aren't taking. Only Parkinson's patients are taking those medications. So in Alzheimer's disease, because it's only related to the disease pathology, it tends to occur later in the illness. So those would be maybe a couple of differences, but there certainly is overlap.
Okay. So earlier, when you started the presentation, you were talking about hallucinations, delusional behavior, that this is an awake state manifestation. I think that for some, it can be confusing because at night, there can be all sorts of behaviors, REM sleep behavior disorder. I don't know, some people have even experienced loved ones of sleepwalking. And it's sometimes, I think, hard to differentiate between what is something that is part of a sleep disturbance and something that's part of an actual psychosis. Can you talk a little bit about what that is and what defines the sleep state versus the psychosis state?
I think for the very reasons that you just said, the confusion is why we have to kind of draw an arbitrary line that what we call psychosis, what's defined and accepted to be psychosis, is only what's happening during the waking state. Because in other disorders, those symptoms aren't only while somebody's asleep. It wouldn't make sense. But yet, while you're asleep, we already know, right? People, as you said, can sleepwalk, they can dream. In Parkinson's, they can have vivid dreaming behavior, the rapid eye movement sleep behavior disorder. You can have nightmares. There's things that happen as somebody's going into sleep and out of sleep that can occur, what are called hypnagogic and hypnopompic hallucinations. We don't really consider those psychosis, Parkinson's psychosis, because they may be, the symptoms may be similar, but due to a different cause and have a different treatment. So by convention, we're talking about just really what is happening in a full waking state.
So this person had asked if there is, have you ever known someone to have psychosis at the beginning of their diagnosis that goes away?
Well, yeah, I guess there's two parts to that question. Can you have psychosis at the beginning of your diagnosis? And I think there is some emerging literature that there are people with Parkinson's, I think it's uncommon, who even before treatment can have kind of subtle or minor hallucinations or perceptual changes. And there has been some research to suggest that. So I think that highlights that it's not all driven by the medication. It can be driven by the disease process too. And to the second part of that question, I think there is variability in symptoms. Lots of things can come and go in Parkinson's disease, whether it's motor symptoms or non-motor symptoms. I'd say in general that if it's related to the illness or to the medications, that it's probably more likely to be persistent than not unless something changes. But sometimes people can develop hallucinations for other reasons, for medical reasons, even like a urinary tract infection. We don't really call it Parkinson's psychosis, but it's still hallucinations. And those symptoms can improve with medical attention and addressing the underlying medical condition. And so and likewise, the symptoms of Parkinson's disease psychosis can improve with adjustments to the Parkinson's medication sometimes, if that can be done. In terms of just the natural variability of the symptoms, I don't think we really know how much that changes on its own spontaneously.
And then there was a question that came in by direct message that you might not have seen pop up, but there was a question about, so someone can have psychosis, they can experience hallucinations or illusions and not be diagnosed with dementia. So what is, I guess, what is the, the statistical possibility or the difference between people with psychosis without dementia and people with psychosis with dementia?
It's higher, significantly higher. And it may not just be the dementia, because other things go with dementia as well. They tend to be highly correlated, and we can't always tease out the different factors. But I would say if you just took a population, and people have done this, of Parkinson's patients and divide them into those who would meet clinical criteria for dementia versus those that do not, the rates of psychosis will be significantly higher in the dementia group. But are there other factors that could also contribute to that other than just having dementia? Well, yes, because the patients with dementia are older on average. So age could be a contributing factor. They've had the illness for longer. So disease severity could be a contributing factor. People that have dementia are on higher dosages of Parkinson's medications typically. So that can be a contributing factor. Now, sometimes studies do try to control for that. And I would say that in those studies that do, dementia still emerges as a risk factor. But these other factors may contribute as well. And if it is a risk factor, it seems to be, it's probably because those patients who have dementia are more likely to have the disease widespread in the brain. It's less localized, more widespread. And the more widespread the disease is in the brain, the more likely somebody is to experience delusions or hallucinations.
So there was, sorry, my feedback was really weird for a second. So we had a question about which drugs could be responsible for causing psychosis.
Mm-hmm. So there are, within Parkinson's disease, I'll just start there, there are expert recommendations for which ones to discontinue first. And I'll just say, or minimize, decrease. Pretty much everything eventually gets removed if possible, except for levodopa. So dopamine agonists, amantadine, MAOB inhibitors. It's thought that all of them can potentially contribute to psychosis. And at the end of the day, sometimes somebody is left just on levodopa. Even at higher dosages of levodopa, we know that these symptoms can occur. So that's really, I would say, any of the Parkinson's medications can contribute. And then outside of Parkinson's disease, the medications that are probably most notorious are what are called medications with anticholinergic properties that affect the acetylcholine or system or transmitter. And that can include things, there's actually Parkinson's medications which are not used commonly anymore that are anticholinergics like trihexyphenidyl and benztropine. But then there's other over-the-counter medications like Benadryl is an anticholinergic medication. There's other medications that can also have anticholinergic properties that older patients are not uncommonly on. So those can worsen or contribute to hallucinations. Steroids can cause hallucinations. And then we just try to get people off or on lower dosages of other kind of CNS, central nervous system medications, benzodiazepines, so those are anti-anxiety agents, narcotics, anything like that can potentially contribute as well.
So we had a couple questions around what is the options or recommendations if Pimavanserin doesn't work. So we had one person who said their loved one was actually in a study and they also tried it again for 6 months and didn't have any luck with it. And then another person had written in, what is the recommendation? If it does not work, are there other antipsychotics that they should try if that one doesn't work?
Yes, so that is not an uncommon scenario. Medications, even ones that work on average, which is what a study does, it's comparing the average to averages of a relatively large population, but doesn't mean that every individual is going to respond. And we already know that clinically that's not true. So I'd say the three main antipsychotics to use or consider using in Parkinson's disease would be pimavanserin, quetiapine, and clozapine. It's just clozapine, it's just so uncommonly used just because most people find it impractical. But there are clinicians that I know use it routinely, and so they just make it a part of their practice. But those would be the three that are most either commonly used because the neurologist is comfortable or there's the most evidence for it. And then everything else, you're kind of in uncharted territory, but that doesn't mean things can't be tried. They just have to be tried very cautiously. So you're monitoring for motor symptoms in addition to worsening of motor symptoms, in addition to other tolerability, but also improvement in psychosis. But there's many, many antipsychotics that are potentially available for use in Parkinson's disease.
And then you had mentioned the use of citalopram, can't talk, it's a mouthful, for Alzheimer's disease agitation. Is that something beneficial for somebody with Parkinson's and agitation?
I would say we don't know. So I typically do use antidepressants for anti-anxiety effects, because benzodiazepines can have side effects. And I also use it for these kinds of psychiatric symptoms. I use it for pseudobulbar affect, that one syndrome I mentioned, because antidepressants have been shown to be effective for all of those, if not in Parkinson's specifically, at least in general population or other populations. So I think antidepressants are kind of a first line for many things when you're trying to avoid other medications that may have more problematic side effects. But whether antidepressants work for agitation has not been studied in Parkinson's, and I don't think there's any reason to think they're effective for psychosis, specifically hallucinations and delusions. that hasn't been studied in Alzheimer's even. It's only been for really agitation.
And then I think we have time for one more question. And this was around more of the experience of having a loved one experiencing hallucinations. So this particular person says their wife sees her hallucinations daily, names them. They're elaborate, sounds like family information, where they work, which houses in their neighborhood they live, and they don't really know how to navigate those issues. So outside of, you know, medication management, is there anything that you could suggest in terms of just as a care partner dealing with those kind of experiences?
Yeah, so that's a big question to be the last question at the very end of the
know,
talk. And that was
why I just came in, or I would have given it to you earlier.
And I don't think I would have been able to answer it adequately anyway, partly because it's not really my area of expertise. And that was why I did on the last slide say that that's an important component, non-pharmacologic approaches, and that's been studied in Alzheimer's. So I tend to look at the Alzheimer's literature for that. And there's actually, in my area, one of the leaders in the field, she's the dean of the nursing school at Drexel University, named Laura Gitlin. So if anybody ever looks her up, Gitlin, you'll see trials in big journals like JAMA and other top medical journals looking at caregiver education and behavioral management trials for agitation and Alzheimer's particularly. And I think they really go through like the ins and outs of how to consider behavioral approaches, redirection, different strategies. But there are kind of strategies that are well written up about how to manage these symptoms, whether it's psychosis or agitation. Mm-hmm. So and whether you're doing it on your own just by educating yourself, or whether you're working with an actual therapist, is, you know, there's different ways to do it. But probably it's hard for me to say more than that just at the very end.
Yeah. Well, and we have had a couple of comments in here of, you know, other places to get information like the Lewy Body Dementia Association. They have a lot of great resources. There is an expert in the field of occupational therapy who works with a lot of people with dementia, agitation, Teepa Snow, and she has a variety of resources on her webpage, including videos of how to navigate different behavioral issues. So that's another great resource. And someone had asked earlier also about whether this is going to be recorded and the slides available. And yes, Kelly had dropped the link in. If you want to save your chat, if you go over to your chat box, the three little dots, pop that up and it'll give you the opportunity to save your chat. So if you want to be able to go back and reference some of the things that were stated in terms of resources and that link, that's where this recording will be. And Kelly also dropped in some information about Teepa Snow. We've had her on before. She's really good at dealing with dementia-related behaviors. It may not be specific to psychosis, but certainly those more agitated, confused behaviors, how to redirect and how to kind of minimize the situation and how to approach. So Dr. Weintraub, thank you so much for a really interesting conversation. Again, this is a very difficult topic. I know some of these questions are hard to answer, but I appreciate your candor about it. And I want to thank everyone for joining us and invite you, if you don't have your screens on, if you would turn them on for just 1 second, because PMD Alliance has a special way of thanking our speakers for their time and their expertise, and that's giving the wave of gratitude. And there's nothing more fun but to see all the waves to the doctors from all across the United States. So we all give you that wave of gratitude. We thank you so much for your time. Everyone.
You're welcome. Thank you for the invitation.
Absolutely. Everybody have a great rest of your day.
Bye.